So first of all, gratitude and thank you for giving me this opportunity. So this was the topic which was given, and probably I would be taking uh, this session for about 20 to 25 minutes. So the topic that was given was diagnostic challenges in hemoglobinopathies, emphasizing thalassemias. I just modified it a bit as hemoglobinopathies and thalassemias are a group of hemoglobin disorders, as we all know, and we have some illustrations at the end of it all about how we approach these cases. But to start with, again, a disclaimer that there's no sponsorship or anything with any particular instrument. And most of the illustrations which we have put across is about the values, and we have not gone into the basics of cell counters or the histograms. And the graphical data which you'll be seeing is more of capillary electrophoresis. I have not worked much with HPLC, so most of the illustrations which I've come across, which you will come across in this presentation, is from the capillary electrophoresis. But the concept for both, when we are analyzing a hemoglobinopathy or thalassemia in any of these platforms, is very similar. So that has to be in mind. So I hope all is well, and it's a weekend, and uh, we're all excited about it. But why have I put this slide is because, so let's say there is about this song in particular, when there is a diagnostic challenge, it may be a very confusing case where you have the knowledge about whatever parameters we ask. So let's say we have a case of thalassemia where you have the complete picture about how the electrophoresis is, how the cell counter data is, how the clinical presentation is, everything. So then there might be a difficult case, and you know that, okay, this is a diagnostic difficulty. But there may be another scenario, as we have in this movie, where he says how my child cannot interpret a normal letters. And most of it, if we look at a strange language like this, though we know how to read, but not this language. So that can also be a diagnostic challenge. So if you're not aware what exactly a thalassemia is, or let's say a thalassemia minor, how do we recognize this? Even that's a diagnostic challenge. So I'm just splitting what our introduction or what the title is. So my question is, red cells indices are a must when we are reporting hemoglobin electrophoresis. Any answers in the chat box? You can just say yes, no, maybe. Question is red cell indices important in reporting hemoglobin electrophoresis? Any answers?
Yeah, people have replied yes.
Okay, fine. That's good. So I hope everyone are using the indices. We'll come back to this question later on. So another terminologies which you have to be very familiar when we are speaking about the hemoglobin disorders is, again, what hemoglobinopathy is, what thalassemia is. Both are very interconnected basically. And what exactly are the red indices when we say it as thalassemic indices? So this is from the very familiar textbook with the pathologist, that's Henry. And if you just refer this particular page numbers 577 to 591, this is in the 23rd edition, you will get such an immense knowledge about how exactly the thalassemias and the hemoglobinopathies are, and definitely it will be kind of a ready reckoner when you want to report hemoglobinopathy. So in this, when they say it's about both are inherited disorders of hemoglobin, and when there is structural variants with defects in the structure, those are called hemoglobinopathies. Whereas thalassemias, it's about the defects in the synthesis of a globin chain. But these can overlap basically. So let's say if it is hemoglobin E homozygous, you will look at a thalassemic indices but you know that it's a hemoglobinopathy. On a look, the indices are thalassemic, but there will be no elevation with the A2, but there is a abnormal band altogether. We'll come to that slowly. And any doubts, just please put in the chat box or please convey it to us. So, what exactly is thalassemia indices when we have known what is hemoglobinopathy and what is thalassemia? So, whenever you have a low MCV and a high RBC, as in this example, MCV is at 67, and this is a female patient. So 76, let's say, is the normal MCV. So 67 is way below. With MCV being low, MCH also low, and RBC being higher. So 5.5 is the cutoff for a female patient. But in this case, it is 5.94, that is high RBC. So whenever you have a low MCV, low MCH, high RBC, with usually a normal hemoglobin or let's say mild anemia, something like 11 or up to 10 even, sometimes 9.5. Those which are mild anemias, but you have RBC count being normal or higher, this is what we call as thalassemic indices. So whenever there is a report like this or a CBC data which has come up like this, where you have MCV low, MCH low, RBC high, that's when we have to suspect that this is a case of a thalassemia minor or thalassemic carrier state. These are two articles which we would always recommend when if we are starting to learn about hemoglobin A2, because they speak a lot about how exactly the quantification should be, what are the variations that can happen, what are the pre-analytics that we have to be aware of. It's a very wonderfully written articles, and it's about 5 to 7 pages, and uh, you can just go through it, both of it. And then in the same article, they just speak about how the peak of HbA2 should be. So your peak, shape, separation, and baseline when analyzing the sample that does not contain variant hemoglobin, just like this. We don't have any variant, and this is from a capillary electrophoresis. You have the zones named across as A2, E, S, A, and so on. So, which does not contain a variant hemoglobin. Peak should be Gaussian and symmetrical. What that exactly means. So, if you just say it's like any of your cell counter histograms, they are kind of smooth and they are symmetrical. They follow the Gaussian distribution, which we would have learned in our basic statistics. So this is how an ideal am I audible? Hello?
Yes, you're audible.
Yeah, yeah. So like, was I not audible for a while or something?
Just for a few minutes.
Okay, fair. Like, where was I exactly? If you can just help me
The
track.
Gaussian distribution.
Okay, I'll just come back to it. Okay, so in this particular article which we just saw, so you have these two particular articles which say in depth about how hemoglobin A2 should be measured and what are the pre-analytical variables. And in that, they have this particular paragraph where they say,
Sorry to interrupt. Your screen is not visible.
okay, just a minute. Think. Just a minute. Think. Visible now?
Yes, sir, it is visible.
Yes, visible.
Yeah, sorry. Uh, so these are the two articles which we spoke, and in that your HbA2 peak should always be symmetrical like this with a Gaussian distribution. We just put across three examples of when your A2 cannot be reliable. So let's just zoom into those three. So we have these three data points. So one, if we just look at the HbA2, uh, this is not touching the baseline and it's not symmetrical. So the value that comes out of this is not reliable. And again, if you look at the second example, this is not symmetrical and it's kind of not uniform. So again, that's not reliable. But in the third example, if you just see, it follows the Gaussian distribution and it's symmetrical. So this would be reliable. So these are the few things which we have to be aware of whenever we are reporting electrophoresis. Now we'll just come to a scenario where we are looking at an antenatal checkup in an urban setup and a rural setup. Hello?
Sir, your screen.
Yes, you're.
Yeah, I think there's some connectivity issue. I'll just give me a minute, please. Uh, I'm audible now?
Yes, sir, you're not.
Yes.
Yeah, like where did it stop exactly? Hello?
At this point, when you were talking about the differences, at the point at the beginning of the slide.
Okay, fine. Okay, so let's get back to this. So I'm very sorry for the trouble. I don't know why there's been a frequent disconnection. So basically, let's say we are looking at a CBC, which is MCV decrease and RBC increased, whereas hemoglobin is normal. And there is one more scenario where in a rural setup, let's say we are just doing hemoglobin and it's just normal and we are not looking at indices. So with whatever we have learned till now, what's the next test you want to request? Can anyone just put in the chat box about what next test is required? Okay, PS is few. Anything else? Iron, because we are speaking about hemoglobin being normal. So iron studies, yes, but hemoglobin being normal, iron deficiency would not present more often like that. So there's someone who has asked us electrophoresis and RDW. So we'll take it. So let's say we have requested electrophoresis for this particular patient. And there are a few things which in your instrument, you can use it as a screening tool where you can just put your fractions flags as one of your screening tool and it would say A2 is being elevated and there is a star mark if the graph is abnormal. So these are few things which you can add in your LIS when you are actually analyzing these things. We'll come back to that thalassemic indices again. So this one thing which we have built in our LIS whenever there is a microcytic hypochromic anemia, there is an alert for the pathologist who is seeing this, saying what is the probability of PIDA is possible iron deficiency, and if it's a BTT, that's a thalassemia carrier or minor thalassemia. So once this alert is there, we always would have a look at this in detail and see what exactly it is. And this is just one of the examples where MCV being low and hemoglobin being normal and RBC being higher. So we would say that it is more often confirmatory that we are looking at minor thalassemia. So just that these are the few alerts which you can build in your LIS, because let's say you're screening about 300 CBCs per day. We tend to even miss it, but these are a few things which you can build. Thought we'll share that. So in this particular case where the LIS had flagged it as possible thalassemic carrier, the A2 was elevated and this was beta thalassemia. So we'll just run through a few cases about what exactly a thalassemia is and what difficulties you may face in the routine reporting. So this is a 25-year-old male who has come for a routine health check. We are looking at MCV low, RBC on the slightly higher side. So PS looks fairly fine. We can appreciate a lot of microcytic hypochromic cells. And then this particular patient, we just ran even the A1C because that was requested as part of it. In this, what you can see is there is an exclamatory mark beside the A2. The cutoff is in this particular program is usually 3.5. But when we run it on electrophoresis, hemoglobin electrophoresis programming, we have set it at 3.7 basically. So elevated A2 is there. So this is a beta thalassemia minor. So this is the same sample which is run in the hemoglobin electrophoresis mode. We see that there is no A1C which is there. But A2 when we see, again, it's kind of almost symmetrical, touching the baseline. So 4.3 is a reliable value. So the diagnosis is thalassemia minor. But we could reach to this diagnosis only with the help of the red cell indices, which gave a clue because they were thalassemic, and then the electrophoresis, which was there with elevated it. Coming to the next case, antenatal check, MCV of 67, which is low, MCH 20, which is low, HB of 10.2, again, anemia, 4.8 million is the RBCs. What next test, or I would say, do we need electrophoresis in this particular patient? Do we require electrophoresis in this particular case, or you would say no? Can anyone just type in the chat box? We're looking at MHA with mild anemia. Yes, okay. So initially we thought it might be just iron deficiency, but yes, the indices almost look fine, except for that RBC is slightly on the higher side. So we just looked at the smear. It's microcytic hypochromic, quite some target cells here and there, nothing much. Poikilocytosis is very minimal. And then electrophoresis actually showed elevated A2. So here, again, when we are looking at it, it's almost symmetrical, which is there. So 5.1, we know that it's elevated A2. So that is beta thalassemia minor. But the anemia is possibly because there's concurrent iron deficiency. Serum iron profile was asked in this particular patient and iron was low. So you may have cases where it may look just like iron deficiency, but in an antenatal check, it's almost always good to do a hemoglobin electrophoresis just to see whether they're actual carriers or it's just iron deficiency. Now coming to the next case, 24-year male has MCV of 58, MCH of 19, which are low, RBC of 6.91, which is high, hemoglobin 13.4, that's normal. Now, the smear examination showed a lot of target cells and electrophoresis was done, and it is showing a normal A2 basically. So now would we still label this person as a thalassemia carrier, or we would say we have got A2 as almost normal, we'll skip it? How many would say we still have to evaluate for uh, like he's still thalassemia carrier and it's the electrophoresis is still normal, but he is still thalassemia carrier? Or we would say that he is not thalassemia carrier at all. Any takers? Okay. So let's say A2 is normal, but since our thalassemic indices are so much there, we still call them possibly they are thalassemic carrier states. So, okay, there's one query about saying rerun the sample after iron studies. So again, speaking about this is a male patient and we are looking at 13.4, which is almost a near normal hemoglobin and RBC being high. That's against iron deficiency. But A2 coming normal, this can happen just because this particular patient we have looked at, we did both the beta and the alpha PCR, and there was IVS15 mutation in the beta, and there is a mutant in the alpha. That means usually alpha would always reduce the A2 and beta always elevates A2. But when both being there, we can always get a normal A2. But the clue in this particular case was such severe thalassemic indices. So the message is that whenever we have a normal pattern in electrophoresis, but the red cell indices showing thalassemia or thalassemic indices, we should order a molecular study and that would give us an answer about the thalassemic carrier state. So the question was about red cell indices are a must for reporting electrophoresis. Definitely yes. So which I was always fascinated with this particular quote from William Osler, who said, to study the phenomena of disease without books is to sail an uncharted sea, but if you study books without patients, it's like not to go to the sea at all. So very similarly with the electrophoresis, if we are just looking at electrophoresis and say, okay, A2 is normal and I would not want to call this person thalassemic carrier state, maybe sometimes you may be right, but if we are reporting it without the red cell indices and the smear, it's like not to go to the sea at all. So I have a couple more cases. We have time still?
Yes, Pradeep.
Yeah, okay, okay. So we have two patients here, 17-year-old female. These are the findings in the CBC. You have hemoglobin of 7.3 in one, 7.4 in one, almost very similar values, just that case B has slightly lower MCV. Anything else would you want at this particular point along with these indices to put it across what may be the cause of anemia? Any other indices that can help?
Saying peripheral smear.
Okay, but any other indices in the cell counter which can help still further across?
Maybe
Yeah.
RDW.
Yeah, so RDW. So let's put RDW here. So 18.6 and 26.1. And RDW, as we know, is a measure of anisocytosis, at least. So we know that we have to look at a lot of variation in this particular case, case B, and rather than in case A. But with the values, let's say we are just looking at these numbers and we say, okay, this is just microcytic hypochromic anemia and let's proceed further. So this is of case A. We have a look at the smear. The variation is not much, but the microcytic hypochromic RBCs are very striking. You have few elliptocytes there, there's some target cells. But then this is the next case where the RDW was so much, and there's a lot of fragmentation. It's like if we ask any particular shape of RBC, it's there. A lot of these fragments, which are so small, very marked poikilocytosis, marked aneuploidy. So what are we looking at? So we just compare it side by side, case A and case B. We saw these two girls clinically, and case A had no organomegaly and case B had a splenomegaly, basically, along with icterus. So what do we think we are dealing with? Any other test do we want in this particular cases? Okay, someone said it's pyropoiculo OFT. Okay. Anything else? Okay, someone had told a reticulocyte count. We
Yes.
would require a retic count of automated or a manual in this particular case. I'll wait for the answers. Manual. Okay, that's great. So there's striking poikilocytosis in both. So let's get to the thing here. So this is the electrophoresis of case A. The A2 is almost normal, so nothing much. OFT was asked in this particular case, case B, OFT was decreased because of microcytic hypochromic anemia. And then they had asked even a EMA because there was one query of about pyropoikilocytosis also, but EMA came normal. But electrophoresis revealed a fast moving band in the zone 15. So whenever you have this in zone 15, and there are people who have requested for manual reticulocyte count, will do a supravital. And supravital in case A, you have few reticulocytes, but nothing much. Here we had reticulocytes, but along with that, we have a lot of golf ball inclusions. So that particular smear finding of such varied poikilocytosis in a background of microcytic hypochromic anemia, literally no NRBCs being there, and that's when we have to look for a golf ball inclusion in a case of MHA. The degree of poikilocytosis is always marked, so that's one thing which I always want everyone to keep in mind. So this is the golf ball inclusion, which I hope that's a clear one. So whenever we have microcytic hypochromic anemia, we look at the smear, look for the poikilocytosis, whether it's mild or severe, get the details of whether there is organomegaly, icterus, is there any intermittent transfusions that patient is going on. If there is no transfusions which have been there, no icterus, no organomegaly, it's a straightforward case of iron deficiency. But if it's there, organomegaly, icterus, and there is intermittent transfusion, we think of thalassemia intermedia. In this particular case, it was HBH disease. So coming to another case, at 4 months, there is a transfusion dependency anemia, and the NRBCs which are there, look at the smear, there's a lot of poikilocytosis, NRBCs being there here again. This is F being elevated. So this is a straightforward case of beta thalassemia major. So this is a homozygous state is what we would say. We just put this case across because we get a lot of queries about when we diagnose infants like 2 months, 3 months, 4 months, less than 6 months, basically when we can pick a thalassemia major. It's very much common than what we usually assume. And that's the reason like we have India is thalassemia capital, basically. So this is what we looked at the first scenario, where in a rural setup, they said hemoglobin is nearly normal and we will follow it up. This is the mother who has thalassemic indices of MCV low, RBC high. The father, again, MCV low, hemoglobin normal, RBC high. So the electrophoresis of both the parents, you have beta thalassemia trait in both of them. And so that's the final diagnosis. You have a homozygous beta thalassemia, which is major because of the transfusion dependency and the severity of anemia in the child, whereas it's thal minor in the parents. So just to speak about hemoglobinopathies, where this is one more spectrum, which is double heterozygous HBE beta thalassemia, which will always present more often like a intermediate or major. And this is one of the articles which speaks in depth about how hemoglobin E thalassemias are. And in that, if you just see mild to severe disease is E beta with no concurrent alpha deletions. So just to bring back about why electrophoresis cannot be reported alone. So let's say we have this example of F being 31, sickle being 67, A2 being 1.1. Now, if we actually match this data of F being 31, we almost might call it HPFH based on just these two data points. But that's when we have to have a clinical picture about whether the patient has a severe symptoms or they are mild. So this particular case, the clinical expression was severe, hemoglobin was low, and this was homozygous sickle cell disease. This is a nice table from Henry, and whenever you have a sickle bind coming up in your electrophoresis, you can always refer to this. There's one more in Daisy where they speak in depth about how heterozygous states can be with the concurrent alpha deficiency, alpha globin deletion. So these two are the ones which we would recommend you to read about. So the last case, so there's 3-year-old female transfusion-dependent anemia from the age of 6 months, and we have the CBC data. Hemoglobin of 10.5 is near normal for a 3-year-old, but indices are normal, slightly low RBC count. If you just look at the histogram, it's absolutely fine. The only flag they have given is fragments. Just did a peripheral smear for this, and literally nothing. There's no poikilocytosis, hardly any anisocytosis, nothing much. So did the electrophoresis for this almost normal? So the question is, from the clinician point of view, a transfusion dependent anemia, and this child had thalassemic phases, and there was icterus, there was splenomegaly. They are thinking right in terms of a thalassemia major, but we have these particular data points. So how would do we think that it's nothing, it's not hemoglobinopathy and the anemia is something else, or are there any takers who want to say that this is still thalassemia? We are speaking about a 3-year-old kid who has been having transfusion dependency anemia from the age of 6 months. Clinically, they are thinking in terms of thalassemia major, but none of the lab parameters, including smears, CBC, or electrophoresis, is favoring thalassemia. So, it is thalassemia or not? Yes, no. Any takers? Okay, someone says yes. So, okay, I think we have another answer. Uh, one of the queries is it H's? Morphologically, it was not H's, but clinically, it was thalassemic phases and everything. It is pointing towards things. So okay, so one of doctor has, yeah. When was the past transfusions and molecular studies? And that's exactly what was requested. The transfusion was just 1 week back for this particular kid, and whatever we were seeing was because of the transfusion. It was all transfused blood, and molecular studies were requested, and we had IVS 15 and codon 16, which is there, two heterozygous. That means we are looking at a homozygous beta thalassemia in this particular patient. So all in all, with the clinical picture is actually very important. When we just had a case where clinically they were thinking in terms of thal major, but none of the lab initial studies were looking like that because of the transfusion. we have to look at the electroforces pattern very carefully. We have to take support from the red cell indices. And of course, we should never forget to see the smear. So unless all these three are there, just a minute. So all in all, if we have all these four things when reporting a hemoglobinopathy or thalassemia, that's when we can reach a diagnosis. So since the next talk is about the transfusion, I just thought I would put this across, which I saw on World Thalassemia Day. And it's really painful whenever we see a kid of beta thal major, because they go through a lot of these transfusions, and it's very painful thing, but we can definitely prevent it when we can pick a lot of these thalassemia carrier states. So my gratitude to the organizing team from the CAHO, and for having given this opportunity to speak, and colleagues here at NRL, and the patients who have been very kind whenever we have requested for history, and the clinicians as well, because they give their inputs about how exactly they have, and my teachers in my past uh, educational institutes. Thank you.
So thank you, Dr. Pradeep. Excellent lecture. Just one more thing, what I liked is involving our delegates. That's an amazing thing, asking intriguing questions so that I also couldn't stop answering. I think that's a wonderful thing so that, everybody is involved. There
Yeah.
was one feedback from, I think one is, I think from Dr. Manoj, that the second last case, he says he would rather go for parents HPLC rather than expensive molecular. Yeah, it can be the take of, I mean,
Yeah.
you can give your comment.
Yeah.
And obviously, I think one more feedback. So that's it. If you can want to add on that, I think.
Yeah, so actually, I think the parental screening was done, but they wanted to document the molecular part of it also. So we had got the parent sample also. We actually did molecular on that particular, both of the samples, but they wanted molecular for all three to document and see whether when they can take the particular kit for transplant, basically. So, but since if we actually put that across, probably I thought the suspense would be revealed very sooner. So I thought I would put it that way, just putting molecular in the end. So that we cover.
Absolutely. I think one more thing, Dr. Jyoti, I think Dr. Pradeep, or all of us who are into uh, practice where we are talking to the patients and clinicians, the most important thing is counseling at
Yeah.
each and every stage. Let's not leave it to the clinicians because,
Yes. Yes.
everybody is tied up into, like, the moment we see something where there is, as you rightly took it in a very nice way, where we see even MCV and RBCs,
Yes.
the second thing is call up the clinician frantically and tell them that is there any organomegaly, or
Right.
is there some, many times in small labs, I don't want to generalize, but when I move across Maharashtra, we
Yes.
see if the bilirubin is slightly elevated, labs are very scared and they change it a little bit here and there.
Yeah.
This is the actual
Yes.
scene in our
Yes.
country.
Yes.
And I think it's an eye opener, and we must have more talks addressing this issue, which is completely
Yes.
preventable, like we
Exactly.
do on
Exactly.
maternal screen.
Yes.
I
Yes.
think that is further ahead. If we address even these things, we can really reduce the burden on the family and our country and prevent, these conditions. Thank you.
Yeah.
And excellent talk, I think,